They defined a low-risk state characterized with low cholesterol, low blood pressure, no smoking, no diabetes. And if none of these factors are present, the risk of having a heart attack is extremely low. But less than 10% of the population belong to this low-risk category. There's high negative predictive value, but there's very few of these persons. When there's very few without risk factor, consequently there must be many with more than one risk factor. And it was published by the same group in JAMA last year, major risk factor as antecedents of fatal and non-fatal coronary heart disease events. The risk factors was high cholesterol, blood pressure, smoking, and diabetes, and nearly 90% of the population had one or more of these risk factors. These major risk factors, they account for coronary heart disease, but they have low positive predictive value because, as we have heard, also patients without developing ischemic heart disease have these risk factors. And there is no major difference in the presence of one or more risk factor in the population that will not develop atherosclerosis and coronary heart disease and those that will have a heart attack. And it was also mentioned in this letter a few months later in JAMA that the predicted power of one or more risk factor for coronary heart disease is extremely low. A few months ago, the INTER-HEART study was published in Lancet, and it also confirmed that worldwide the major risk factors account for myocardial infarction, but they are rather useless for prediction. Why? Because these risk factors tell you the exposure for causative agents for this disease, but it does not tell you whether the individual are susceptible or resistant to the disease. We miss this component, the susceptibility or vulnerability to the exposure of this risk factor in current risk assessment. So, in current risk assessment, it is based on risk factor characteristics by calculating the Framingham risk score. And based on this calculation, you decide how to treat the patients so that the treatment match the intensity, match the risk of the patients, and you treat the causative risk factor. It is the existing guidelines. You miss the vulnerability aspect in this assessment. What about existing guidelines? Because there is in fact exception to this rule that risk assessment is based on an assessment of these statistical associations with risk factors. There are in fact people that has declared themselves as being vulnerable. And these patients, what is happening? And in these patients that already has declared themselves as being vulnerable or susceptible for the disease, you don't need to count risk factors. In this report from the National Cholesterol Education Program Adult Treatment Panel 3, published in year 2002, there is a chapter on the concept of coronary heart disease risk equivalence and other form of clinical atherosclerosis should be treated as aggressively as people that has established coronary heart disease. It is peripheral arterial disease, it is the presence of carotid arterial disease and abdominal aortic aneurysm. And in this evidence statement it is said that if peripheral arterial disease is present, detected by an abnormal angiobrachial index, reduced flow or symptoms, but there don't need to be symptoms present, these patients should be treated as if they had established coronary heart disease. They should be treated aggressively. Carotid arterial disease, similarly, if there has been transient ischemic attack or stroke of carotid origin, or an asymptomatic stenosis of more than 50%. So there don't need to be any clinical symptoms from the carotid artery to qualify as a coronary heart disease risk equivalent. But it's not the same for the carotid intimal medial thickness, where it is stated specifically it does not raise risk to the level of a coronary heart disease risk equivalent. There needs to be plaque in the carotid arteries and abdominal aortic aneurysm. But it was coronary heart disease risk equivalent. It was disease in other vascular territory that indicate if it is present, then you should treat aggressively as if the patient has established coronary heart disease. There is also a chapter of emerging risk factors and subclinical atherosclerotic disease. And also in this section, the angle brachial blood pressure is mentioned, test for myocardial ischemia, and then it's in fact flow limiting property of atherosclerosis. But then there is also test for atherosclerotic plaque burden, disease in the vessel wall that does not cause limitation in blood flow. If a stenosis is present in the femoral artery, it should be treated as if coronary heart disease is present. It is a coronary heart disease equivalent. If myocardial ischemia can be detected in asymptomatic persons, it is coronary heart disease and should be treated aggressively. Regarding plaque burden, it's not the same. If the intimal medial thickness is above the 75 percentile for age and sex, the person may be upgraded, elevated to a higher risk category. And with a high coronary calcium score, the same may be the case. You may elevate the patient to a higher risk category. So already in current guidelines, there are situations where you add a test, and if you can detect the disease in the vessel wall, it can have some consequences on risk assessment. But in current guidelines, you start out with measuring these risk factors that are statistical factors associated with the disease. And what is new in SHAPE, it is rather than focusing on risk factor, we focus on the disease itself in the vessel wall, the plaque burden, the amount of the disease. And based on this detection and assessment of vessel wall disease, we assess the risk. And then, of course, from this risk assessment, we have to reduce the risk if an increased risk is present. And for that, we need the causal risk factor. We don't need these more than 200 risk factor. We can go down to the risk factor we know that has a causal significance for the development of the disease. And here we have the paradigm that Mort already has presented. We start out by risk assessment based on the detection and assessment of the disease itself in the vessel wall and its plaque burden. Then, of course, you can discuss what should the threshold be, what is the cutoff point for risk stratifications. And we have some suggestions here, but of course it could be discussed. It could also be discussed what is the role of CRP in this algorithm. And then we have risk reduction, the intensity of treatment that is determined by the amount of the disease in the vessel wall. We also have seen it before. I think it was Mort that showed it. This collaborative initiative that was published a few months ago in Circulation for the prevention and early detection of cancer, cardiovascular disease, and diabetes. And we can see screening for cancer. It's the disease itself that are in focus. We are screening for cancer, but in coronary cardiovascular disease, we are not screening for the disease. We are screening for some factors that are statistically associated with the disease. Here I have with the number of people that died of these cancer in year 2001, and more than 500 million died of atherosclerosis, and we are not screening for atherosclerosis. And I think it's a paradox. So it's a new in SHAPE. It is risk assessment that is based on the assessment of the disease itself rather than its risk factor. Is it better? We believe it is, and we think we are ready to go for it now.